and examples from eClinicalWorks, which is one of the systems that we implement in MedAlley. Okay, so core demographics. This is an example of one of the objectives, is record patient demographics that includes sex, race, ethnicity, date of birth, and preferred language, and then more than 50% of all unique patients by the eligible provider have demographics recorded as structured data, meaning that it can be reported on. So the way we set it up in eClinicalWorks is that the front office staff needs to collect this information, and we need some fields that are mandatory. So this is the eClinicalWorks registration screen, and as you see, we've made date of birth required, sex required, and then when they click on the additional info tab, the 3 additional fields, race, ethnicity, and language, are now required, and the drop-in boxes appear. So that's an example of one measure and how you would achieve it in an electronic health record. Another one is recording vitals, height, weight, blood pressure, calculate the BMI, plot the growth charts for children. You want more than 50% of all unique patients aged 2 and over seen by the eligible provider. The height, weight, and blood pressure recorded as structured data. In this case, the most appropriate person to do that is usually the nurse collecting the vitals. In our system setup, we have to map vitals, set them as mandatory, and carry forward the height any patient over 21. In the electronic health record, this is an example of eClinicalWorks. They have this grid. These are mandatory fields now where they enter the height, weight. It will calculate the BMI, blood pressure, and for the children, they can click on the growth charts.
Another question?
Sure.
Adults, you have to keep recording height?
In this system setup, we've had the height carried forward after the age of 21 as part of the system setup.
Okay.
So if the electronic system can do it, you're set. If it can't, you will have to record it. I feel like Susan going super fast there. Okay, computerized physician order entry of medications. You need more than 30% of unique patients with at least one medication in their medication list seen by the eligible provider have at least one medication order entered as CPOE. So you are prescribing electronically in the system. In this case, the actor is the physician who is usually prescribing the medication. Part of MedAlley's training in order set creation training stage 1 is the class that we teach how to set this up. I'll show you what it looks like. So in this particular EHR, we have things called order sets, which are quick ways to list medications, to list the labs typically order, the diagnostic imaging, the procedures, immunizations, and future appointments. So in the system, a physician can meet this by prescribing the medication, which these 2 buttons right here. They want a follow-up done on this patient, and then basically they click the order button. That will shoot those prescriptions over to the pharmacy electronically for the patient to pick up. It will also schedule, send a notification to the front office staff that this patient needs follow-up. Electronic prescribing. In electronic prescribing, the way we set it up is the front office staff is responsible for collecting the preferred pharmacy for the patient. You want to do that at check-in. They usually ask, where would you like your medications to go to? Both mail order and retail, and then more than 40% of all the permissible prescriptions written by the EP are transmitted electronically. So in the application for the physicians, they would click e-prescribe. The electronic prescribing screen would come up. They would confirm that they want this medication, and they would send it electronically. Drug-drug and drug allergy interactions. The one we like about this one is it takes no effort. It just needs to be set up in the system to be enabled, the drug interaction check. So we call it a freebie. You get a freebie, you don't have to do anything. You can satisfy a measure. All you have to do is make sure this is enabled with your vendor. In eClinicalWorks, we know it's enabled because the interactions come up when the 2 medications are trying to be prescribed together. Core clinical visit summary, another objective. For every patient that comes into the practice, you are providing more than 50% of the time a clinical visit summary. This is one of the hardest measures to achieve with our practices because it's a change in workflow. The after is the front office staff or the physician can print this out. So your check-in, check-out, or your doctor, depending on the workflow in your practice. You have to set up visit summary defaults in your print option, which I'll show you the screen for an EHR. And it must be done individually in this particular application by user. So each user has to have this set up. This is only printing out certain sections of this soap note. I'll show you what it looks like. In this system, there is a function called print visit summary. At the end of the visit, the office staff, the physician, clicks this button. The system's going to ask you. You can set these as default. Medications, so anything you prescribe, any tests you order, any referrals that you've sent out, when their next appointment is, any health recommendations, their diagnosis, any immunizations you've given, and any preventative medicine guidance appears on that summary. You can uncheck some of these. You can just have a default that they're automatically checked, and then you do print. Now, providing the clinical summary is a mandatory objective in the core set. So this is, the numerator is the number of patients in the denominator who are provided a clinical summary of their visit within 3 business days. We want to set it up a couple different ways because this can require a lot of printing of paper. For this particular application, there is an option to set up a patient portal where those patients can receive the visit summaries electronically. You have to give it to the patient within 3 business days. So if the patient is leaving the practice, now you have mailing cost. So that's why we have the workflow when the patient leaves the office to provide the clinical visit summary. It's based on the patients in your EHR. So you can use all the patients, but the EHR is going to calculate by what you've done in that print button. So don't create extra work by creating a document to print and hand to the patient. It will be done in the system. For this and percentage-based calculations, we encourage practices to aim for 100% on this, and the EHR objective is only 50%. We strongly believe that in stage 2, the optional measures and the 5 out of 10 will go to 10 out of 10 in stage 2. So if you're going to make workflow changes in your practice, it's easier just to aim for the 100% now than to go back and try to redo the workflow or add the additional workflow in stage 2.
Can you, sure. So for this, so this is a core measure, so we must meet this 50% of our office visits.
During that reporting period.
Right, so what you're saying is at the end of the patient visit, before they leave, we print a summary and
hand it to the patient.
Well, print a summary.
Yes, print a summary. I can tell you as a patient in any clinical work practice, it is actually great. It summarizes my visit, when I'm supposed to be back, what test I'm going to get. So it's also good PR for the practices because the patients really like having that summary and their medications are on there. And if they can keep that medical summary, if they're going to another provider, it's easy to hand that to a provider and say, this is what I got done in my last visit with my primary care, and hand that to a specialty physician.
Going back, how does CPOE prescribing medications differ from e-prescribing?
Okay, so you can send a prescription via fax to a pharmacy where when you're prescribing, you hit that fax button, it goes to the fax machine just like you're sending a regular fax. CPOE entry of a system is the electronic connection to the pharmacy information system. So in this country, most of what we send is through SureScripts. Are you familiar with SureScripts? Which is like a big pharmacy hub. So it connects the mail orders, it connects the retail pharmacies through this big SureScripts hub. All the EHR vendors have a connection to SureScripts, so they are transmitting it electronically. It goes into the pharmacy information system directly into the computer. So it's CVS, it pops up in the inbox, and actually I was fortunate to get the tour of CVS and how that works on the CVS end and go behind the scenes of the pharmacy with one of our local pharmacies because the pharmacists were claiming that they never received it. But it is all tracked. They can receive it, and if there's an issue, SureScripts will investigate it with the pharmacy and say, no, this was confirmed from your information system and acknowledgement received. It is tricky if you've done electronic health records. Luckily in this region, because of the high adoption rate, a lot of pharmacies are on electronic. But when we started this, 7 years ago, it was like pulling teeth to get pharmacies to understand. A patient would come in and say, I have a script. They emailed the script, and the pharmacy would normally say, we don't accept emails. And then they would call the practice back and say, we don't have it. I think that's evolved a lot in these counties, especially with the groups that have adopted. It kind of paved the way for you guys to get pharmacies compliant, so it's rare that I have a non-compliant pharmacy that will do that.
But if you do an e-prescription, does it also give you credit towards the CPOE measure?
In some practices, there are staff that actually control prescriptions, but that doesn't come the same way as the physician sitting as the patient is transmitting it, or is it the
Whoever's
same?
allowed to send that prescription electronically in the practice, and that would be per practice policy. So if you have somebody that's saying, okay, a nurse is allowed to send this medication, and she's allowed to send it to the pharmacy, that would be, it's just calculating that patient's med sent electronically to the pharmacy. And patient meds.
Just so I'm straight, the clinical visit summary is going to be printed up at the end of the patient's visit and handed to the patient.
Yep.
All right, now what about if you have an office where multiple languages are spoken by the patient? And some patients we're an office where there's a lot of indigent patients there that don't even read or write. They sign their name with an X. How is that going to help?
Well, the regulation is to print it, and they didn't.
And it doesn't go anywhere. It doesn't mean anything.
Right, it doesn't mean anything to the patient.
It's just for paper.
Or if they, English is not their primary language, but the requirements for the print
I
button.
guess they didn't take that into consideration.
Well, and just one quick comment. We've been working with the health center on this issue, and one of the things that a health center with a strong indigent population, non-English speaking, one of the things they've been saying to the patient is, keep this, share it with a family member who's involved with your care, or if you go to see another doctor, take it with you. I know it's not perfect, I completely get it, but that is the strategy that they've been telling.
I have a question about that.
It doesn't show helping the patient, it just shows that you can.
The vendor that I happen to be using at this point in time did state to us, because we're on this topic, that if a patient doesn't want it, you do not have to print it, you just have to sign it. But there's no mandatory law that says you have to print these and give them out if the patient doesn't want it. You just be wasting paper.
Correct, but you have to trigger whatever the
Trigger it.
mechanism behind the scenes in the EHR is to print it and calculate that total. So in eClinicalWorks, it's the print button. And I understand that you can print and then cancel the print right now in the system. So it's really, it's the technology that you have behind the scenes.
Right.
But there's no regulation that says in it, I mean, you should hand it to the patient and give them a copy, and they say, I don't want a copy, that's fine.
Okay.
Okay, so there are, just some technical additional information. So the providers are permitted but not required to limit the measure of the objective to those patients whose records are only maintained in an EHR. So they are not calculating if you're in the middle of a transition to a paper chart, the paper chart's in there. The provision of the clinical summaries is limited to the information that's contained within the EHR technology, meaning that that information exists already, your problem list, your medications, your allergies. If the eligible provider believes that substantial harm may arise from the disclosure of information, so you have a patient that maybe has some mental health illness along with their regular medical problems, you can choose to withhold that information from the patient, and providers are not allowed to charge the patient a fee to provide the information. Okay, I'm going to go quickly through a clinical quality measure, and this is the hypertension blood pressure management clinical measure. So how they're calculating is that for patients who are age 18 and older and they have a diagnosis of hypertension, who have been seen for at least 2 office visits with a blood pressure recorded. The way they calculate that, you'll recognize either the hypertension and ICD-9 codes. If they appear in the EHR and the patients are 18 years or older and they have 2 face-to-face encounters in the reporting period, the patients must have at least 1 blood pressure recorded in their chart in the vital signs. Here's an example. Patient in eClinicalWorks has a problem list. Hypertension appears. They're over 18. The way we've set it up in the system is that when the vitals are entered, we've created those to be mandatory. They are yellow. The blood pressure is entered from 20/80, and you satisfy the measure. Do you want me to keep going with examples? This is good? Okay. This is the adult weight screening. The follow-up measure definition is percentage of patients who are 18 and older with a calculated BMI in the past 6 months or during the current visit documented in the medical record. And if the BMI is outside parameters, a follow-up plan must be documented. Here's an example of meeting this type of measure. We've calculated the height, weight. The system has calculated the BMI and the weight chart difference. So what we've done is we've created in the templates a way to document that the meaningful use adult weight follow-up and assessment, or if it's a child, we've put in there a standard template that providers can use to meet this measure. Makes it a little bit easier. So we would select the adult weight follow-up assessment, and what would appear in the note would be the dietary surveillance and counseling code, and then the way we worded it is BMI management. Patient was counseled on a weight management program. I specifically reviewed the patient today, attaining a healthy weight, following exercise regimen, appropriate for the patient, and patient-specific counseling was provided on diet and nutrition. So that's whether the patient is overweight or underweight satisfies the measures because I've documented follow-up plans. So MedAllies, we have a chief medical officer who has worked probably for about 5 months on how to take the electronic health record and meet each of the core measures and who is the appropriate person to do that actor role in a practice. We developed a guide for our end users and our practices to actually step-by-step. What I showed you were actual sections from our guide on how to achieve this. I think a lot of the vendors, I know we also implement NextGen, has this type of walkthrough where you can go through a reference and say, this is how the information is calculated. We took it a step further and actually said, not only is this how it's calculated in the EHR, but who's doing what at each point in the process. Meeting meaningful use is not easy. The step-by-step guide is 133 pages with screenshots. So this is, a program that requires some work. What we've been seeing with our practices is about a 3-month time to get their numbers up on their dashboards, which I'll show you real quick, to say that I'm meeting meaningful use. So if you're about to implement EHR, the day you go live does not mean you meet meaningful use. So I'm going to show you some tracking systems. For eClinicalWorks, they have MAC dashboards. They call MAC dashboards, which will show where they are on the dashboard. And these particular measures, the physician who's in the green, numerator and denominator are calculated. But on these measures in red, they still have not met the threshold. So most systems, certified systems, have a way to report this out. This is one vendor. These are the quality measures. Green when they hit the quality measures for that practice, and they've selected these to measure out. And I've also shown you, just so you can have a comparison to another system, this is one of our NextGen clients. Same kind of thing, different format, tobacco use and assessment, tobacco cessation, what their numbers are for 3 other doctors who hid their identities. So MedAllies tracks on our stoplight tracking board our clients and where they are, what program they're going with, how many providers they have in their practice, and if they hit green, red, or yellow on their core menu items, where they are with their attestation. When the practice hits all greens, we've had practices hit all greens, MedAllies helps them walk through the attestation on the CMS website. We've been happy to report that they are getting the money. They're very excited. So that's just a taste of what it's like to be in an EHR and configure a system. The next section is about selecting an EHR. For those of you that have an EHR, you're welcome to stay. Those that have implemented, you're welcome to stay, but you've been through this process before. Any questions about what it looks like in an EHR? Does that help see a visual of how you set these things up for the practices that are in the middle of this? And we'll make the slides available if you contact the us, of course. Yep.
I just have one question regarding the patient education part of the meetings. If you have patients who come in multiple times for the same thing, we do pediatricians with kids with sore throats and ear infections, must we print one instruction sheet for sore throat every single time they come in?
No, you just need to print once.
Once ever in their, that year?
That they received the patient education.
Just once.
In a year or ever, like when?
I have to, let me get back to you on when the time period is. It's in the 133-page guide. Okay, so now we're moving on to practices that are looking to do EHR implementation and what you're gonna go through. And I will cover this in super fast speed and then take questions. Okay. Implementing electronic health records, there are areas, and this is my implementation solar system. There are things you're going to go through in this whole process that you need to understand and ask your vendors when you're doing the EHR implementation. There's a project management component, an IT computer component, it's how you build the system. This becomes critical. The thing I can stress is when you are building a new EHR system, make sure you have the meaningful use guidelines with you because you want to build those into your system. Data migration is how you get your existing practice management data over to your EHR. That's your billing information, your patient demographics, what insurance they have. Chart abstraction and scanning. How am I going to get my paper chart to electronic? The misconception is that we are going to wake up one day and everything will be electronic. It is typically we see a year process depending on how fast your patients come back to the practice for you to fully become electronic or all your records or your paperless. So a lot of salespeople will be like, oh, you've got EHR, everything will be fine, it'll be totally electronic. I just want to dispel that myth. Training and go live is critical. It's just like studying for an exam. The more effort you put up front into training, it will pay off. So we really want to emphasize what the vendor's providing for training. Again, meaningful use, keep those measures next to you while you're doing your system setup and work with your vendor. Modules and interface activations, laboratory interfaces, radiology interfaces, EKG, spirometry. When will those be live and set up in the system? And who's providing my support, and where's the call center? And are they going to be responsive? And I'll make these slides because I have some references in here that you can go to. So for project management, you want to assess your current state workload. How are you doing things now? MassPro put out a great guide that you can use to assess your practice and think about how you're going to do that in the future. Also included information technology assessment. When you put computers into a practice, you want to pay attention to where you're placing them. So if you set up, if your nurses work one-on-one with your physicians and they do the initial intake in the exam room, it doesn't do any good to put a desktop in the hallway for the nurse. That's not where they're collecting their information. So you need to understand where that workflow is occurring so you can appropriately place the equipment. If you have, I had a practice that had a triage nurse, perfectly fine, she sat at the desk all day, did triage with the practices, desktop was fine for her because she was on the phone. We also do a readiness for implementation. We have some practices that actually are not ready for EHR implementation or need some tweaking. This includes making sure you're financially viable when you're going through this, making sure your staff is prepared for this, making sure you have the right hardware and the leadership's ready to do this project. The way I explain it to practices is this is the hardest project you will ever do since medical school. And I am not sales, so I can say that because I do the implementation and the support side. It is not an easy project, and if you have vendors saying this is a piece of cake, it's not. So we set the expectation with the practice. It is a very difficult thing to achieve, but if you hold tight and hang on, you make it through the process. This is just an example of our assessment, and I included some examples of project plans. So when you're working with your vendor, you want to ask them, what is my project plan? Can I have a copy? Who's managing my project? What resources do you need on my side to assist with the project? This is for a very large implementation that we did. We actually had to create a Microsoft project. This is an example of Excel. So for the physicians in the audience, you can kind of see what to expect when you ask for a project plan. Information technology. Information technology is the foundation that your EHR is going to sit on. If the foundation is cracked, you are going to have problems with EHR. And I see this 100% of the time when practices don't focus on IT, EHR doesn't work, it doesn't go well. So you want to understand what are the hardware requirements for this vendor. You can't use Windows Home Edition, Student Edition to run a clinical information system electronic health record. What are the network requirements? What do I need to connect in my office, those computers together? How do I protect my practice in terms of firewalls so there's not intrusion from outside sources? And what are the connectivity requirements if you're doing the ASP, cloud, or web-based model? That's all the same term, but you're accessing the information remotely and there's no physical server. What the caution I will give you from doing this for 10 years. EHR is a specialty of IT. In the medical world, it's like a specialist. So you can have a great IT person, they are very knowledgeable, but if they have not experienced EHR, you're going to have trouble. It's just something you learn over time in tweaking routers and understanding that this particular type of computer doesn't work well, like the IBM ThinkPad, this model. You don't want to experience the testing of that while you're going live with an EHR. That can kill an implementation. You also want to make sure a person who has IT background that's been through this understands the future state workflows and why they can't put a printer on the opposite side of the office for prescriptions because the doctor is going to, for the controlled substances, be walking across the office to retrieve that. That comes from experience of doing EHR implementations. Vendors can be certified or preferred, and you want to get recommendations from your vendor. Who would you recommend to do our IT for the EHR project? And these problems, this is probably one of the 3 main things that can destroy an implementation, because if the doctor cannot function, he or she is the only revenue producer in the practice, and you are losing revenue every minute that practice is down, the physician's down. Scheduling, billing can get by with a system down. A physician cannot get by, especially when all the charts are electronic. So that the cautions are things you want to ask your vendors. System configuration and build. When you're building the system, make sure you involve everybody who touches that process, including medical records, your front office. You don't want to build a system assuming that the appointment schedule should look like this without input from your front office staff. What I caution you is when you have an electronic health record, you don't want to pave your cow paths, meaning because you had a paper chart before, you don't have to follow that process anymore. Your patient is digital. It frees you up to do all sorts of things. Multiple people can access charts now. So don't limit yourself. If you are creating workarounds in the paper world, you have the opportunity now to do enhancements in an EHR. For example, I have practices who have insurance listings that have been there for 20 years, and it's Empire Plan misspelled, Plan Empire. You don't want to put that into a new system. This is your opportunity to clean up that insurance listing, to clean up things you put into your practice management because they were workarounds. The system couldn't do something. MedLS has recommendations for what you need for the system configuration, and you can accept those or say no. For our practice, we want to do an exception on those and start testing your workflows early. When you think that you are going to collect a copay now in EHR world, when the patient checks in and you're going to scan their license and you're going to scan their insurance card, you want to make sure you test that process. If the patients start coming in EHR world and you're asking them for the copays on check-in, which is best practice, and the patients start saying, I don't want to pay the copays, you've got to be able to quickly change that post-live. You may say, wait a minute, Mary, forget it, we're going to go with the checkout process. And you have to do that quickly. So for a practice, when you're modifying the workflows, you want to make sure you're testing. Walk through a check-in process, walk through a checkout process, walk through a rooming patient. I had a funny story with a pediatric practice where the doctor wasn't used to reading which exam room the patient was in. In EHR, it's electronic. Remember before you put the charts up here and you know which patient's in which room? So I was shadowing the physician and I looked in the EHR, it said the patient was in exam room D. He went into a different exam room. I didn't go because I knew it was the wrong patient. So he walked into the exam room, realized it was the wrong patient, said, oh, I have to go get some paperwork, I'll be right back. So it's something new to physicians. They were used to the charts and the flags before, now the chart's electronic. This is an example of future state workflows. For those of you who haven't seen diagrams like this, I've given 2 examples of what they should look like. You can read through them. This is for new patient surgical visit for one of our practices, and this is for a nursing visit. Data migration. So this is your practice management system. What I caution you is look at your practice management system, determine how clean the data is, how old is the data before you transfer it into the system. There's actually practices I recommend don't transfer the data, it's not worth it. The other caution, which I didn't have on here, is your current vendor for practice management will charge you an extraction fee to get that data out of there. There's only one system I've seen where they actually don't charge for an extraction, and that's LITEC. For migrations, either from taking it out of your practice management system, your demographic, insurance information, and putting it into an EHR can be disastrous. I've had practices where the IT person has pulled the wrong data file from the practice management system, the old data file. When we put it into the EHR, it didn't look right. There was something wrong. So in medical manager, they had medical manager, and then the old version of medical manager and a backup file for medical manager. They pulled the wrong one. So when you're migrating the data to your new system, make sure you double check that data. Check hyphens, check data bursts, check a lot of patients and make sure that they look okay in the new system. I've also had a pediatric practice where they pulled the data, and because some of the coding was off in the computer language, there was a pediatric practice and all the patients' data bursts were 1 to 150. So it became a geriatric practice real fast. And the reason we knew this is because all of a sudden Medicare alerts popped up for every patient to get them to sign it. Like, what's going on? And then wait a minute, the data bursts are 1 to 150. The computer people were able to go and alter the file. It was just a character off that caused that computer to create that. So you really want to get a good sampling of your patients, check them in your new system. Chart abstraction and scanning. This is something vendors typically don't talk to you about until it's too late. Chart abstraction is getting discrete data into the electronic record. And when I say discrete data, I mean typing it in to the system and it is reportable, as opposed to scanning, which is scanning a picture like when you scan documents. It's a picture. The computer just thinks you're one big blob picture. What we recommend to practices is get ready for chart abstraction now. You can't start too early on chart abstraction. So in your paper medical record, you probably have a form that has the problem list, allergies, and or medications on it. You can create a new form to collect that information, but this information needs up to date, and if it's centralized on a form, when you get students or hires that are going to be keying that into the system, they can go much faster. So if I have, and I have, students that can enter 200 patients in a day because all the information is there. If I enter the problem list, the allergies and medications, I can start e-prescribing in the system very easily. It makes the transition much easier for the physicians. You can abstract more data into the EHR pre-live. The problem is it costs more, there's more time, and you have to gather that information, so there's a trade-off. Scanning information into the medical record from your paper chart. I recommend do not scan your entire chart in the record. I've only had one practice do it. The doctors don't look at the data. It's very expensive and time-consuming, and it sucks up a ton of bandwidth on your network. What I tell practices, if the doctor were to call the practice and say, send me this from the paper chart, fax it to me, what would this be? The last note, the last lab, the last radiology. Whatever that list is what you want to scan into your EHR prior to your go-live to get some information in there on the patient, enough for the physician to get that visit started. So for practices that, even if you haven't selected your EHR, you can at least start thinking about your chart abstraction and scanning plan. The practices tend to use mostly family members to do this project over the summer and over the holidays. So the best advice is when the kids are getting ready to get out of school, that's kind of when you want to do your chart abstraction, because you can get a lot of that caught up, and they're very fast with the computers. They're keying in, you know, they pick from the problem list, they pick the meds, they pick the allergies. They are just the scribes to get it ready for the physician. The physician will verify that information on the first visit. And I had one pediatric physician who had 2 kids in college. And I paid for their college and their books, now they did chart abstraction all summer for me. So they did it. They sat in his office and they did chart abstraction for quite a while. And do you have a question?
Yeah, even if you scan things into the computer, you're required to keep the paper for many years anyway.
Yes.
So it doesn't make sense to scan.
Well, this is more.
Papers available.
Well, this is more to get the electronic records started. So let me give you a scenario. We usually tell practices it's about 3 times that you're going to see the paper chart before you retire it and not have to pull it anymore. And you can change that rule, but the ballpark's about 3. If I abstract Diane's problem list, my meds, and my allergies before my first visit, they're in the system. If I scan Diane's pertinent information from the last visit, it's there. So when a physician sees Dianne for the first time, I'm going to have a kernel of information available to me so I can do my first note electronically. So I'm going to do my first electronic note on Dianne. I'm going to have the paper chart here, and I'm going to pull out any other things that I need to add to that visit. Then I'm going to mark the chart once. The chart will be returned, medical records will return it on my second visit. On my second visit, not only do I have my problem list, allergies, the meds, my scan, plus I have my last visit completely electronic, I will get the paper chart again. I will go through that whole process and create my second note electronically. If I need anything from the paper chart, I'll flag it, they'll scan it into the system. It's usually 3, and it really depends on the patient. I mean, if you have a sick patient, you've got volumes, it could take you a lot longer than a healthy person coming in for a physical. Once that doctor feels comfortable that they don't need anything from that paper chart anymore, they can mark it for chart return, and it gets pushed aside. What it saves is that staff not pulling that chart anymore, because they can indicate in the EHR, I don't need this chart, so don't pull it. So when they get the patient listing, they will see, pull these, don't pull these. And usually we see a 3-month period of time where patients are starting to come back now electronically, and then when they come back 6 months, and then when they come back a year, the chart, you don't need the paper chart anymore.
Can the paper chart be off-site at that time?
You can store the paper chart off-site and just be retrievable. One practice stored it in the basement. You know, the doctors were adamant that they were going to have the paper chart, so they stored the chart in the basement, and if the doctors wanted it after the 3rd time they had to go to the basement to get it, they weren't that interested in the chart. Training and dedication to training. It is critical that you reduce your patient load for the first visits you do in the EHR. If you don't, you'll pay for it later. You got to get the physician time to get comfortable doing that note electronically and seeing their patients. If you keep the patient load at typically 25 to 30, and then you force them to keep that pace plus learn a system, you will kill the doctor. They will be working till 2 and 3 o'clock in the morning trying to catch up. The problem is, if they're seeing 30 patients a day and they're trying to catch up and they do 15 at night, there's another 30 coming in tomorrow, and then another 30, and they can never get up. They actually get behind. So reducing patient load to give them time, you can always up your patient load. For practices, there's usually patients calling you saying, I'd like to get an appointment. Bonus, we have slots available this afternoon. You can always up that, but you can't tell patients, I'm sorry, I'm too busy with my EHR to see you today. Like I said, it's too late post-live. I've actually had practices that didn't cut, and then later on they ended up having to slow everything down because the staff was getting stressed. You will need additional training resources if you have to come back and do that over. It's just, it's worth the investment in saying, look, let's take the time, learn this system, and then implement it. What you don't want to do with physicians is get them in front of a patient when they are not ready to use the system. It's a bad experience for the patient, and it's embarrassing for the physician, because you don't want to be there going, how do I get here? And you're not even, patients will say to you, hello, can you look at me? Can we not have the computer in the room? Because you're so focused on the computer. The general benchmark for readiness to go into an exam room with your tablet or laptop, or if you have a desktop in there, is you can do a visit in 5 minutes or less. You can do the visit 5 minutes or less in your test system, you're good to go. When Med-Al is implemented, we actually do a staged approach now because it's too much to do all this at once, so we've staged it. Get the physician comfortable with the system. Stage 2 is actually do the notes electronically, because that's a much bigger leap. I can order prescriptions, I can order labs, radiology, and then I will do my note on paper until I get comfortable with that, and then start my electronic record. Training and go live, you want to make sure that the end users have an environment where they can learn. Humans cannot learn when there's people asking them questions and patients calling on the phone, and that's uninterrupted time. We've had practice say, well, can you train the people in the waiting room? Can you train them in the hallway? They need to focus and learn this system because it will pay off in the end. This is an investment in how you run your business. With most of the vendors, they have webinars, videos, a training database. Let them go wild and learn that system and get comfortable. Unhappy front office staff will translate to patients. I hate this computer, I don't know how to check in, this is terrible. Patients getting that message don't have a pleasant experience in the practice. You want happy staff going, oh, this is great, I have your information, I'm just verifying your insurance, Mrs. Smith. Patients go, wow, I don't have to fill out all those forms again. And they talk to other patients about their experience in the system with other patients in the community. You want to require every end user achieve a high level of proficiency in the system. Again, know your meaningful use, create your workflows. The example I gave, who's going to collect smoking status? Where is it going to be collected? How often are we going to run reports? And this is the website for the resources on meaningful use. Modules and interface activation. This is important because you need to know what's going to be activated when you go live. Lab interfaces, radiology. If they are not active when you go live, what is the workflow? One of the meaningful use for diabetes measure is you have to collect the hemoglobin A1C in a structured format and reportable. If you don't have a lab interface that's going to populate that, somebody's got to key in the hemoglobin A1C. If the lab is not going to be available for a year, that's a lot of keying. You're going to have to know which labs have to be keyed in and have staff to do that. Most labs will pay for interfaces if you have enough volume with them. You want to make sure you talk to your labs to see if they are in fact going to do that. I had one practice where they were denied by both Quest and LabCorp. Lucky for them, the hospital built an interface. Timing is important because you may need temporary workflows till these interfaces go live. Super users are critical to success. So selecting somebody in your practice who is a super user is a huge advantage. We see a big difference in groups. This is the person, and you know who they are. They aren't necessarily the practice administrators. These are the go-to people. So they usually are, who does everybody in the practice go to when they have a problem? It's Mary. Mary is a good candidate for super user. Mary can fix the printer. Mary can unjam the fax machine. Mary knows how to register patients. They're great super users. They have a type of personality where they like to do things like implement the systems and be the resource for the staff. If you can get them to buy into the system, when the physician is going on EHR, they're going to grab the first person they find, and you want them to grab somebody who's knowledgeable and can help them immediately. So when they are stuck, they can go, Mary, how do I enter the HPI for this? I forgot. Or where button do I click so that the provider can keep moving? We strongly recommend at least one practice be certified in the actual application. I know this is costly for smaller practices. It's an investment to have them go through a formal training program and get certified in the application. I've seen super users do some talented things in EHR because they know the system well and they know their providers well. So they've designed some awesome templates and order sets. Okay. They don't necessarily have to be the people in the practice that have power. They could be the people in the practice that people go to. So it may even be a medical records clerk. And then what I included on the slides, and in your packet, I included some red flags for implementation that we've seen that practices make mistakes. Please read this carefully and make sure that you don't flag anything, that you're not following the red flags. And then I have some stars for what we've seen for successful practices are the star slides. The other thing is I want to mention, when you're hiring people now, if you're thinking about doing EHR, make sure that you assess their computer literacy. It'll pay off later. They won't be using computers now at work, but they will in the future. So if you're hiring a nurse, make sure that they understand how to use computers, or you're going to be paying for having to invest time in training them on how to use a computer. So your HR recruitment strategy should be tailored towards somebody that has electronic computer proficiency. And I just did a diagram height, what we talked about today about selecting, implementing, training, implementing the workflows, and then getting the meaningful use money. And most of what I see in practices are practices that have the right attitude going into an implementation. A physician champion, a lead administrator, their super users, they're going to go through a process where it's going to be very difficult. And the lead person, especially the lead clinician, has to hold tight through that process because it gets rocky and people start crying and say they can't do it, and they need to coach them and make it through. Our successful practices, have the attitude that we are doing this whole project because we want to improve care for our patients. That is the goal that we keep in mind through the whole implementation. We are doing this so we can provide better care to our patients. Okay, sorry for the speed thing, but we'll make the slides available. If you have questions, Susan and I will have our contact information. Feel free to reach out to us. We appreciate the time that Bon Secours gave to us for the presentation. I know it's a lot of information, but we're there to help you.
I just want to thank Dianne and Susan for coming out today, for all of you taking time out of your day to come and learn a little bit more about meaningful use, and hope you aren't stressing out too much over software. So Janine and I are here to help in any way that we can. Thank you for coming.